My name is John Morris, and I am the director of the Knight Alzheimer's Disease Research Center here at Washington University. And it's a great pleasure to welcome all of you to the 6th annual Norman R. Seay Lecture. I have told much of this story in the past, but when I became the director of the Knight ADRC, it was apparent that our research volunteers were 96% African American. So we were learning about aging and Alzheimer's disease in white people, and we were unaware to the extent that our findings and our knowledge would translate to people who were not white people. So we clearly needed to do this, the diversity of our research sample, and I had the idea to form an African American advisory board to counsel us on the best ways to engage the community and to overcome barriers to African American participation in research studies and research studies at Washington University. We had the good fortune that Norman Seay agreed to be the founding chair of the African American Advisory Board. This is about 10 or 11 years ago now. And Norman has remained a force and a font of wisdom on the African American Advisory Board, although he decided after some years to relinquish the chair of the board. When he did so, we wanted to think of some way to provide him with an appreciation of all that he has given us, and we decided to launch the Norman R. Seay Lecture, held annually. There's some debate about this. The medical school says it has a named lecture for an African American, but it really wasn't named for the person. It was named for the institution whose name, the Homer Phillips Hospital. They have a lecture, but it's not really for honoring Mr. Phillips. It was what the hospital meant to the African American community. So I hold that the Seay Lecture is the first established annual lecture in the School of Medicine named for an individual, and it couldn't be a worthier individual than Mr. Seay. So, Norman, if you would just wave to everyone. And again, we can't begin to thank you for all that you have provided us. I know that there are a number of current advisory board members in the audience today, including our current chair, Ida Goodwin-Wolfuck, who is at the very back of the room. And if all advisory board members would stand up. So Jesse and Collins and Ida in the back. And thank you, and Joyce, thank you so much for your contribution. So I will now introduce the chairman of the Department of Neurology. Neurology department is the administrative home for the Knight ADRC, and we are very, very fortunate that the chair of the department not only is a wonderful chair, his main research interest happens to be in Alzheimer's disease. So the two go together very well. But Dr. David Holtzman would like to welcome you. Dr. Holtzman?
Well, thanks very much, John. It's really a pleasure to be here at the 6th annual Seay Lectureship. And I really want to thank Dr. Morris and the entire faculty and staff at the ADRC for making this ADRC, I think, unarguably the best one in the world. I think it's really an honor to have the ADRC within the department and to support it in all its efforts, especially in promoting sort of outreach efforts for diversity. And I also really want to thank Mr. Seay for doing the same. I think it's made a big difference here. It's been a real pleasure to meet with Dr. Griffith today, and I look forward to his talk. I'll let John say some more about him in a moment, but it's been really fun reminiscing about some people that we've met in common over the years, and I really look forward to hearing what you have to say. So thanks, and I'll let you introduce him.
I forgot, I'm supposed to tell you all the housekeeping tasks. My memory's not so good, so you'll bear with me. So if you'll take your cell phones and put it on vibrate or put it on silence, and if you do need the necessary rooms, if you walk out that door or that door and turn to your right, they're just opposite the elevators, which are just to your right. And there is a light reception that will be held after the lecture. You know, lots of people spend lots of effort, and the ADRC is really a very collegial place, and many people chip in, volunteer. But much of the work for the Seay lecture is coordinated and organized by Jen Phillips from our Education Corps, and particularly by Myrtis Spencer. Is Myrtis in the room? I think she may be right outside. Becky, is she out there? She's all the way out. In absentia, let's thank Jen and Myrtis. Dr. Consuelo Wilkins is a former ADRC investigator, and now she's the Director of Care and is still the chair of the Seay Lecture Committee, and she will do the honors of introducing Dr. Patrick Griffith. So,
actually, John, before we start, if anybody wants to move over to the left, because the screen is broken and we only have a smaller one, if you want to move over, this is a good time to.
Good idea. So, actually, Patrick, if you would come up here.
Sure.
Good afternoon. It's my pleasure to serve once again as the chair of the Seay Lecture Committee. And on behalf of the committee of the Knight Alzheimer's Disease Research Center, we'd like to present this plaque to Dr. Griffith for being our 6th annual lecturer, and we appreciate you coming.
Thank you.
So this is always an honor for me to serve in this role as chair of the planning committee. I don't have the responsibility of doing as much of the work, so that always makes it better. So I thank the rest of the committee for all of their efforts as well. It's certainly great for us to be able to honor Mr. Seay for his contributions to our Alzheimer's Disease Research Center, our medical school, our community, our world. So we appreciate that. It's hard for me to think of a better person to serve as this year's Seay lecturer. Dr. Patrick Griffith is someone who I've come to know over the years, and he serves as a great role model, a physician and a mentor. Dr. Griffith has a very extensive CV, but it pales in comparison to his kindness and giving and the amount of time that he's willing to offer junior investigators and colleagues, the advice that he's willing to give to support your career. And so I certainly want to thank him personally for those things, as they don't always come out on the resume or the CV, and they're really priceless. So Dr. Griffith comes to us from Morehouse College of Medicine, where he is a professor of medicine in the Division of Neurology. Dr. Griffith is a neurologist, and he's done a lot of work in Alzheimer's disease, specifically in African Americans. Dr. Griffith was educated, he got his undergraduate degree at McGill in Canada, and he got his Doctor of Medicine from Howard University College of Medicine, my alma mater. I like to say you can be great and not have gone to Howard, but it's much more difficult. Dr. Griffith volunteered for the Air Force, where he served our country, and we thank him for that as well. He did his internship and residency at the Harvard University hospitals. I could go on and on about the list of accolades and publications that Dr. Griffith has, but I just want to highlight a few. Dr. Griffith has received the Merit Award from the Atlanta Medical Association, Physician of the Year awards from numerous organizations, outstanding service and distinguished contributions, as well as Outstanding Physician of the Year awards. Prior to returning to Morehouse, Dr. Griffith was the chair of neurology at Meharry Medical College, and so we're happy to have him today as he brings his wealth of knowledge and experience to talk to us about African Americans and Alzheimer's disease.
This is my disclosures, and Jennifer said that we needed this for CME, so I have no disclosures. This gentleman is the father of one of my wife's friends, and in 1992, what does that mean? Okay, that won't happen again.
After top button under the
Top button, okay. In 1992, so 20 years ago, we were being approached to do public education and use the print media to inform the Atlanta community the answer to the question that was posed in my first slide. Are African Americans part of the Alzheimer's disease story? And the answer is yes, but it's probably different in 2011 than it was 20 years ago, and I'll try to show you how it's different. So this gentleman was being recruited for a registry, and the registry was being led by Al Heyman at Duke. He's a neuroepidemiologist, and he was trying to get a national registry to include minority subjects, Hispanics, African Americans, Asians, etc. So our institution was approached to contribute, and we thought that the way to get that started was to advertise what we were doing in the media. The other thing that I learned from working with this gentleman is that we teach our residents and our students, if you take care of an Alzheimer's patient, you have two patients. You have this gentleman that we're going to call the proband in some of the slides that you see, and then the primary caregiver who was his wife. And the humbling experience was that this gentleman's physicians called me from the emergency room, and I got a chance to meet with Dr. Christopher this morning, and we're talking about emergency room contacts. So I get a call from Atlanta Medical Center that this gentleman is in the ER with a massive stroke. And the family wants to know, this is 1992, whether or not he should be admitted, how aggressively should we treat him, and what should be done. So I said, well, let me speak to his wife. He said, no, you can't speak to her. She's had a massive ulcer with GI bleeding. That was the price that she paid for taking care of this gentleman at a time when we were not offering clinical trials, when we were not offering support groups, when we were not offering management that's being done every day here in St. Louis with the ADRC. So for me, that's what I need to take back to my community, the model and the things that you're doing here that we try to copy. This is a cohort of live patients where Dr. Yale was following them over several years and came up with the different kinds of cognitive impairment and chose to use the word by ethnicity. what's important is that at that time, and dates and times become important, in 1996, the prevailing feeling was that if blacks got demented, that they were likely to get vascular dementia, some alcohol-related, and then there were some others. But clearly, they never got proportionally more Alzheimer's than white patients. This is an autopsy study, and I was talking with Dr. Hassenstock, you see it? Yeah, about the pathologist who did this study. So it's 100 consecutive autopsies of the brain at Johns Hopkins Hospital. It's in 1989, and the journal is in the Journal of the National Medical Association. She supported what they thought was going on with the clinical setting, and that is that if Alzheimer's was present in black patients, it was clearly a minority compared to the proportions that you saw in whites, and they tended to have more stroke-related dementia. I'm thrilled that Dr. Morris's group is going to be looking at post-stroke dementia, and hopefully I'm not giving away any secrets yet, but you're looking at whether or not patients presenting with post-stroke dementia probably already have early AD, but that the stroke seems to turn on the train. So in the next few minutes, I'm going to go into a few areas and still be mindful of the time. One of the things about the history, and this is from Steve Salloway at Brown, we did a conference where one of the proponents was talking about Alzheimer's. I was going to talk about vascular dementia, and then Dr. Salloway was the moderator in the overview. And he said that what's happened is historical, that back in the 17th century, the prevailing thought was any cognitive impairment in a senior had to be from arteriosclerosis. And that was what led to some of the early agents that were tried. In 1894, both Binswanger and Alzheimer thought that that was correct. Except that when Alzheimer took the job in Frankfurt to be the medical director for the hospital where patients who were, quote, insane, which is another historical thing that seemed to be associated with this condition, they would be admitted to the hospital there. So in 1901, while working in Frankfurt, he examines a patient who's 51, and he noticed a few odd things. She was probably in what we would call today mid-stage. She was delusional. She specifically had paranoid ideas about not only her husband trying to hurt her, but that Alzheimer was part of the plot. He was scientifically sound enough to follow this lady. He was flummoxed with the fact that she was 51, and so he used the term pre-senile dementia. And back then, if you got into cognitive trouble before age 65, and this has nothing to do with Medicare entitlement, you were called pre-senile. What was smart is that even when he changed to go to Munich in 1904 to the opening of the lab that was run by Kreplin, who became his boss, he continued to follow this person. And he followed her until 5 years later, she passed. So back then, they didn't have long-term care insurance. They didn't have people from the risk management trying to get you out of the hospital. If you couldn't function at home, you stayed in the hospital. So for science's good fortune, Alzheimer had kept notes, and so he wanted to look at this lady's brain. So how does that interface with African Americans? Well, when the lab opened in 1904, people from throughout the world wanted to work with this gentleman who was doing brain research. And his job was to correlate neuroanatomical findings with behavioral changes that he saw in older people. And lo and behold, he only picked one American, one. And that's Solomon Carter Fuller. And he's there with Alzheimer, and I can't read some of the other names of the people, but he was the first American to work with Alzheimer's. A little bit of his history. He was interested in neurological things when he became a medical graduate and did his internship at a Boston hospital. So at age 27, Fuller gets appointed to be the pathologist. And in doing a lot of the sections, etc., and getting help from some of the established neuropathologists in Boston, he then sought more advanced training, and that's where he went in 1904 to work with this new institute. And he was the best person qualified to look at the brains and the histology to work with Kreplin. So, when he returned to the United States, and back then, if you were the department chair, and I know that that doesn't happen anymore, you said nothing, you wrote nothing, you presented nothing, except when the chair presented. And so he never said anything or wrote anything. But when he came back to the United States, he found the first Alzheimer patient that he followed at the Westboro State Hospital for the Insane and published the first case in English, because Alzheimer's case would have been in German. Okay, very important. So much for the history, as I see it. One of the African neurologists noticed that in his practice, and this gentleman has passed on, Oshuntikan, said, you know, I take care of lots of neurological patients in Ibadan, which is one of the prominent premier medical schools in West Africa, in Nigeria, but I never see Alzheimer patients. They said, well, maybe it's how long they live, maybe it's that you're wrong, maybe it's that there's something different about living in Ibadan, but we think it's the first two. Dr. Shuntakun was smart enough to not only get his pathological slides verified at Queen's Square in England, but to work with investigators in Indianapolis. And so Dr. Hendry and some of the others here decided to collaborate with him, and they were going to do prospective, culturally sensitive studies following subjects who were of African origin, living in Ibadan and living in Indianapolis. And this is just a little geography. Here is Ibadan in West Africa, and coincidentally, Fuller was in Liberia here, in Monrovia. Not at the same time, of course. Okay, so what did Oshuntakan know that helped him to convince the collaborators in Indianapolis that this is something worth doing? And the answer is that he saw different risk factors in terms of frequency in these two groups. And the three that are important are hypertension, more common in blacks in Indianapolis, diabetes, and a history of stroke. And that's why, as I say, I congratulate John on what he's planning to do. So these people are set up for different things. So what do? They say, well, you know, the scientific community is going to ask us, how good is your work? So they said, okay, we're going to take non-demented people. We're going to get a big number. We're going to follow them for a long time. And we're going to do the same studies by the same investigators in both places. So it cuts down on researcher bias, it cuts down on errors, it cuts down on people saying that maybe these two groups are incompetent. And what we're going to use as the outcome measure is new cases of all forms of dementia as well as new cases of Alzheimer's disease. What did they find? The prevalence of all the cases of Alzheimer's disease was about 4 to 4.5 times more common among African Americans in Indianapolis. That the new cases of Alzheimer's disease was about 2 to 2.5 times more common in African Americans living in the United States. So the question is why? I don't know, John, that we have answers, but here was an observational, epidemiological, prospective study that raised the question about what these differences are. And what could that tell us, not only about Alzheimer's disease, but what could we do about it? Can we prevent it? Can we ameliorate it? Can we stop it if it starts? So, the take home from this study was that these were competent investigators using the same test materials, following these patients for approximately 5 years, that the native Africans were from an underdeveloped, non-industrialized country, and that the Indianapolis group, you're going to use the same investigators, and then you're going to try to figure out what do these population differences mean, because it may tell us what things you may be able to fix. Because maybe it's something that's fixable that's not necessarily genetic. So, the other thing that was going on at this time historically was that there was some leadership by our former president, but more importantly, back to that same 1992, we see the investigators agreeing that there's a risk promoter gene, and this is the one that's led by Alan Roses from Duke and associates ApoE4 with the problem. Now, parenthetically, just before that, there was a relation to tau, so that they were starting to connect the original histological findings of not only Alzheimer, but the ones corroborated by Fuller when he came back to the United States, that beta amyloid was related to the plaques and tau was related to the neurofibrils that they were seeing. So there's extensive publications about what Fuller did once he got back to Westboro. So this is the signal scientific event that now started to help us get towards where we could better follow who's at risk and maybe what we can do. I was fortunate to have more than a half an hour with the chair, and I tried to pick his brain about ApoE. I'll defer to him in terms of where this is going to take us in the next century, and I think that's the title of your paper, the future. So there's a lot of exciting things to come out of St. Louis. Here's the main clinical work that I did. It's a long time ago, but it's important. We had a grant funded through NINDS and NIH, led by Lindsay Farrar, who is a genetic epidemiologist. And he came up with this study, which is a mouthful, Multi-Institutional Research, Alzheimer's Genetic Epidemiology. And he said, well, you know, one of the things that we need to do is to look at African Americans and their relatives. So it was called Mirage Star. I was the PI in Atlanta, and my responsibility was to get enrollees in Atlanta and that we were going to follow. Now, I can tell you that to convince somebody to get into a prospective study, you're not going to offer them treatment. You're not going to offer them support. You're going to try to confirm the diagnosis clinically because these people are still living. And you're going to follow them. It takes a lot of commitment. And that's why I say we can't move this disorder forward unless we have committed volunteers, researchers, caregivers. Because it's only if we do it together that maybe the next time that you have an anniversary for this wonderful work that's started by Norman Seay, we can have some answers for you. So here's this series of studies, and it's a family study, and what our statisticians told us is let's identify who has the disorder, try to stage them, and then follow what's their lifetime risk. And what we were looking for is when was their incident Alzheimer's disease. We used the same enrollment criteria that Mirage was using, which is that they had access to their medical records, that they had access to their neuroimaging, and as best we can tell, and it was a committee decision, this person did not have anything other than probable Alzheimer's disease, which is what we were using back then. So the highlighted group is the Morehouse group right in the middle. And what we were following was the first-degree relatives. So your immediate, your core family, and then related cousins, aunts, uncles, etc. First degree. Fairly big numbers. And we chose to follow not only the ones that we made the clinical diagnosis of probable Alzheimer's disease, but we chose to follow the spouse. And I'll tell you what that helps us think about. So the cumulative risk, which means for the rest of their life, that's highest in the first-degree relatives, is almost double if you were African American and related to an Alzheimer patient. What was surprising is that we found that the same increase occurred in the spouses. Now, my wife can validate this for you. I presented this when I did a summer sabbatical in Rochester, New York, and they said, this is just absolutely wrong. You know, Alzheimer's is not contagious. It's not an infectious disease. You guys don't know what you're doing. What I had to remind the audience then, and I remind you today, maybe it's common exposure. Maybe it's those environmental influences that were suggested by the work of the Indianapolis-Ibadan cohort. Maybe. So, what we learned from our study is if you're a first-degree relative, and in addition, you're a woman, and you had ApoE4, then you were the one that was likely to come down to this disorder. Just think about that. We did data analysis later, and we tracked using ApoE as the outcome variable. And if you had 2 doses of ApoE4 and you were African American, you were more likely to get probable Alzheimer's disease significantly earlier than age 68. So we were expecting to find more African Americans with probable Alzheimer's disease who were in the pre-senile group like Alzheimer talked about when he described August D. Doesn't mean it didn't happen later on, but that this was the target time. And so that's something that's important, and in terms of health policy, maybe what we should be doing is, and they did this in a study called REVEAL, is the people who are at risk, because you're related, because you're a woman, maybe they should have the E4 test, and then if they're double positive, enroll in a study like is being done here. Because maybe based on what you have now that we didn't have in '92, which is the CSF biomarkers and all the neuroimaging, maybe we can do something. Maybe we can understand what this means. So we looked at other non-genetic factors. Smoking was not associated. Alcohol had a modest protective effect, but it also is alcohol in moderate amounts. And then head trauma, which is the other thing that we're trying to understand. The odds ratio, if you were head trauma, it increased, so they went up past 1. And then for alcohol, it was less than 1, so mildly protective. And this was independent of what the ApoE4 was, suggesting that maybe there are other things that drive an African American at-risk patient towards clinically probable Alzheimer's disease. This is in direct contrast to analysis by the Ibadan group of the Nigerian sample. And what they said is that in their studies, they don't find the same association between ApoE and AD. There also is some studies where they've looked at serum cholesterol and some other markers. So all that's to say that they're probably right, and it's this last line here. There are other genetic factors, and we're looking for that. Our GWAS paper is about to come out in the Archives of Neurology. We have to finish some re-editing that the editors are asking for, but that should be available. So it's either that we're finding, and we have some novel genetic markers and SNPs that we're seeing in African Americans, but that there may be different environmental influences, whether that's lifestyle, diet. You just have to, free your mind and think of what's going on, because it's different in the African Americans and in the Native Africans. This is from a small cohort at Grady, which is our safety net hospital, and Dr. Goldstein is a neuropsychologist, and I got briefed by Dr. Hasselhoff. So basically all it's saying is that if you control for gender, age, and education, that hypertension seems to drive this disorder in African Americans. So maybe if we were to fix that or prevent it or ameliorate it in some way. And the other thing, that this is from the group at Columbia, that the older you are, the risk of getting probable Alzheimer's disease is increased. So the things that put us at risk are age, ApoE4, and being a woman. We had a meeting like this, and Dr. Morris has already told you that the first Seay lecturer was part of this group, and what she taught us and encouraged the scientific literature to consider is whether low education or cognitive reserve was playing a role. It also had to do with where you got your early education, and in her studies, rural education was a negative factor, meaning that you were more likely to have cognitive impairment later on. And for those who are interested, this is the citation, and the second Seay lecturer was the lead author. So, and Hendry, of course, is the guy with the Indianapolis Ibadan. So it's a small group, and we talk, and we try to move the science forward, but it's good reading if you're interested. The last is something that I want to publicly thank my wife for, and that is that she gave us a smart son. So obviously, maternal genes count for something. So Dr. Cacciatorian approached me at the end of this meeting and said, there's a paper from Dr. Weiner at Baylor, and he says that the way to move forward in Alzheimer's disease research is to only study the families who have high prevalence of Alzheimer's disease. That's the only group. You can't do population studies. It takes too long. You can't do targeted study. That's what needs to go forward. My son, who is the first in our family to get a PhD, and I wrote a commentary where we said that's not the appropriate focus. That even though there's inconsistencies with the science, we think that the way to go forward is to understand the environmental factors associated with gene expression. That's the mother lode, that's where the pot of gold is. And if you're African American and you're at risk and you're a woman, then we need to figure out what role diet plays, what role hypertension plays, what role living with an African American with Alzheimer's disease does. And they tell me that the problem for African American women getting Alzheimer's disease is they have to live with African American men. So, how do you manage this condition? The answer is early detection. Bottom line. The sooner you find it, the sooner you can start to put into place whatever needs to be changed to try to either stop it, prevent it, slow it down, whatever word you want to use. The earlier, the better. And how you make that early detection is the kind of things that that John and his group are doing at the ADRC. And this was an invited report that I wrote. I personally prefer the mini-cog because I think primary care physicians are too busy to do the MMSE. It's a reasonable screening tool. It takes 5 minutes. If they're positive on the mini-cog, which is registration, the clock drawing, and the recall, then they should get the full workup. Sue Borson validated this in the state of Washington. It's also been validated in other minority communities, but it's a screen. And if you're doing community education and you want to find a way to find early patients, then by all means consider using this approach. The last is, and I'm speaking as an Episcopalian, so I've tried to pick my words carefully. I think that the well-meaning Episcopalian wants to know that if they start to come down with this disorder, that it's a medical condition, and that's it. And so what I try to do is not only support our church's efforts in respite, etc., but to follow this, which comes from the Alzheimer's Association, that when we identify patients, we try to destigmatize the condition as much as possible. These people have this disorder because of something that's going on. It's not a punishment. It's not a, they must think that way. That's the only way we're going to get further along in this disorder. This is one source, and it's got literature that's written in easily understood language. It's not as good as the MAPS brochures and some of the ones that I've been introduced today, but for those people who look for solace or whatever word you want to use because they have this condition, then this is one source and, that should be considered. For prevention, I don't think that we're very good at working on this side of the story. And this is from Bob Friedland. He initially composed it when he was at Case Western, continued it when he did his sabbatical in Kenya, and he was doing some of the work like the Ibadan and Neapolis cohort, and now that he's in Louisville. And he's been very kind to work with me and to mentor me in terms of what kinds of things can be done. And I would go for this one, that whatever we can do about either lifestyle or diet to decrease this, maybe it'll help. And this one is tricky, especially when so many of our athletes are having head problems. This last one is from not the Barnes who was the Seay lecturer, but the group with Christina Yaffe, and they looked at a meta-analysis worldwide and U.S. of various potential modifiable factors. And the ones that stand out: physical inactivity, cognitive inactivity, hypertension, and depression. Meaning that if you can reduce those by 25%, then you stand a chance of decreasing the number of prevalent cases. And if you combine all of those, you get a really big bang. Somewhere in between waiting for Dr. Holtzman and Dr. Morris's works to give you tangible things, you've got to do things with lifestyle and with diet to help the patients who are at risk. One of the things is physical inactivity. So when I was a young fellow, I told my family that I was quite a track star, and they believed me. But really, the person that I admire is this gentleman, and I think he's passed. But at age 69, he was the Olympic record holder for these events. And what he said was, you get up off your you-know-what, and you start to do something. So when I'm out walking every day, I tell my wife, I'm trying to be like Jim Law. This is a several-page report from the newest 2010 Alzheimer's Facts and Figures, and it's good reading for people who work with Alzheimer's disease patients in African American and Hispanic populations. It's much more likely. The question is why? Number one. Number two, if that's so, what can we do about it? And what kind of research needs to be done? So I kept my watch up here so that I'm not to talk too long, so this is my last slide. And I copied it from this gentleman who's just passed. And he was at Case Western. He was non-American. And they put together this slide series in something called the Henry Stewart Talks in his honor. And it's worth thinking about. He says, the way to get things done is not to mind who gets the credit. Mr. Seay has set up a wonderful legacy. And it doesn't matter if he gets the credit, John, Consuelo, Dr. Holtzman, or I. The question is, can we fix this disorder? That's the question. The second question is, what role do African Americans play in all of this? And if you think about 1992, when the question was first asked of me, and now what I would say is we're a high-risk group. We may have modifiable risk factors. We're getting better at understanding the genetics and the mutations, the novel genes that we're seeing, and we'll be publishing that. But it doesn't matter as long as we get this fixed. So that hopefully very soon you'll have some traction on this very terrible disorder. Thank you.